Hi, my name is Channon Ferraro. Today I'm going to be presenting the overview and treatment of eating disorders. So, the clinical definition of eating disorders is a serious condition related to persistent or repetitive behaviors that negatively impact your health, emotions, and ability to function in important areas of life. The most common eating disorders are anorexia nervosa, which is characterized by excessive restriction of dietary intake, and an obsession with the idea of gaining weight, which these individuals have a fear of gaining weight, which often leads to extremely low body weight and extremely low BMI. Bulimia nervosa is the second eating disorder that is super common, which is characterized by repetitive sessions of overeating or binging, followed by compensation by forcefully expelling food from the body or purging. Binge eating disorder is the third, and it's very similar to bulimia with the binge eating, but the difference is that bulimia has that afterwards compensation of binging and purging, whereas binge eating disorder is just the initial binging and no compensation for it. There are also atypical eating disorders such as night eating syndrome, which is very similar to binge eating disorder, but is characterized by the time of day at which the binge happens, which often it's at night, hence the name night eating syndrome, and purging disorder, which is very similar to a combination of anorexia nervosa and bulimia nervosa, because it is purging without, it's purging during excessive restriction of food intake. So you're not really having that much food to expel, but you still do it anyways. So other than that, eating disorders are often considered psychosocial illnesses because there is a psychological component, which is often the person's own view of themselves and their self-image and confidence. But there's also a social intervention where if an individual has been seeing negative connotations with food and often seeing negativity around food, these people are more likely to be predisposed to develop an eating disorder. These eating disorders are often chronic and will often lead to death if untreated, which is why it is really important to get treated.
Hi, my name is Nestor Mukeba. I am a student nurse. I am here to talk about eating disorder, how people develop an eating disorder. So this disease, there are two diseases in eating disorder. We have anorexia nervosa and bulimia nervosa. I will start with anorexia nervosa. How people develop anorexia nervosa. Uh, Most of the people who develop anorexia nervosa, they get it from the family. Research show that some people they develop those diseases. They come from families where people may have developed those type of disease. So what is happening? It is they have increased level of serotonin. And when someone has an increased level of serotonin in their brain, the serotonin will make those people not wanting food. So those people will dislike food. They will see food like a disgusting thing. Those people they will skip food. You'll see them losing weight, and they'll keep losing weight more and more, and they will look in bad shape. So it is people around them who will see and will ask them what's going on, and if there is no proper care, if the person is not treated, the individual may develop other physiologic disease like malnutrition most of the time, osteoporosis. So if the person doesn't get the treatment, that individual will end up dying. And this is anorexia nervosa. It is linked to genetic, and those people, they have increased level of serotonin, and they don't like food. They skip meals. They skip food. They make themselves losing weight, but they most of the time, sometimes those people, they are also influenced by the society. Especially there are some society where people believe that being fat or being obese, it is a disease. So what they do is people tend to lose weight, especially women. You'll see those people trying to lose excessive weight, doing most excessive exercise, and skipping meals, cutting food. So if someone is doing this excessively, the person will be in anorexia nervosa. And they have also a distortion of their body image. They think that they are overweight, or they need to lose more weight. In reality, they are not like that. In reality, they may have in good shape. They may, even though if they may even be in bad shape, underweight, but they still looking to lose weight. So those people have anorexia nervosa. As I said, it is a increased level of serotonin in their brain, and it is linked to the genetic. In the other hand, we have bulimia nervosa. Bulimia nervosa, those people, they like to eat, to binge food. And as we say, first there is a predisposition from genetic. People can get this from their family, the passing from generation to generation, and in those people's brain, they have more dopamine. We said in anorexia nervosa they have more serotonin, they have more serotonin and less dopamine in anorexia nervosa. But in bulimia, individuals have more dopamine and less serotonin. So when someone has more dopamine, and dopamine is known to be a reward process chemical, so it makes people to do the thing they like the most. For instance, if someone like internet, dopamine will make that person to use internet more and more. So this is what is happening with people who has bulimia nervosa. Those people, first they like food in their brain. Their brain make them like food because of the dopamine. So the more they have dopamine, the more they will be eating food. So you see those people hiding food. You see those people eat food in secret, keeping food in the car, moving from restaurant to another restaurant looking for food. So those people, they love food, they like food, they eat food most all the time. And what they do, they eat, they put their finger in their mouth, they vomit, they eat again. You see them even taking laxatives so they can go to the bathroom, they remove everything they eat and come back and eat again. So those people, they have bulimia nervosa, and they do it in secret. It is not easy to see them, to identify.
The treatment of eating disorders most commonly used is cognitive behavioral therapy, which, according to the Oxford Languages Dictionary, is a type of psychotherapy in which negative patterns of thought about the self and the world are challenged in order to alter unwanted behavioral patterns or treat mood disorders such as depression. The overall goal of cognitive behavioral therapy in relation to eating disorders is overall symptomatic remission, because we want these individuals to exhibit the symptoms of being healthy therefore restoring their body weight and self-image. There are not a lot of alternative therapies. There have been studies for cannabinoids or CBD products, which have not shown significant evidence of being successful. So they're not really recommending CBD treatment for eating disorders at this time, just because there's not significant evidence and there's not enough research on it. But there's also the multi-phase optimization strategy, which is a framework for evaluating the behavioral interventions that mental health facilities are implementing on eating disorder patients. This strategy consists of 3 phases: preparation, optimization, and the evaluation phase. These phases are very similar to the phases of the nursing process, which are assessment, diagnosis, planning, intervention, and evaluation. If you look at the two, you can kind of see that preparation could consist of assessment and diagnosis, and then the optimization phase could be the planning and intervention phase, and then the evaluation phase. So as you can see, these are very similar phases to the nursing process, which often will allow for better research and better treatments to be developed. There are just a few pharmaceutical drugs that can be used, and those are fluoxetine for the treatment of bulimia nervosa and lisdexamfetamine used for binge eating disorder. These are the only 2 drugs that are pharmaceutical and approved for treatment of eating disorders. There aren't very many studies done on the pharmaceutical treatments, but overall the treatment for eating disorders is cognitive behavioral therapy due to the holistic, flexible approach that cognitive behavioral therapy takes.
Let's talk about client education for your patient with an eating disorder such as anorexia. Some things that are important to keep in mind to teach your patient with an eating disorder are what signs and symptoms they should look out for. Some of those signs and symptoms include not wanting to eat in front of other people, compulsive use of a scale to manage their weight, compulsive calorie counting, compulsive thoughts of eating or food in general, excessive exercise, especially after eating or thinking about eating. And then some things to keep in mind about what the disease is doing to their body. Clients with eating disorders may not realize the things that are going on inside of them because of their weight loss. Some of those things include loss of muscle mass, loss of fat, brittle bones, osteoporosis. Anorexia can cause cardiac changes like arrhythmias or tachycardia. It can also cause things like anemia and weakness and fatigue because the body's not receiving the nutrients that it needs. So obviously they're not going to feel like getting up and going, although they are going to push themselves harder to continue to work out. So exhaustion is another thing that they should look out for. It was also important to instruct your patient on factors to look out for that could contribute to their eating disorder. Some things that can contribute to eating disorders are high expectations of themselves or high expectations from family members. If they feel like they need to be perfect, the perfect body shape or perfect body size might be included in that. And so they might continue to strive to get smaller and smaller and never feel like they're small enough. Another factor that could contribute to eating disorders is the need for control. If patients feel like they have no control over their life, like if they feel like their parents control everything they do or their job controls their life, they might try to take that control back by controlling everything they eat, everything that goes into their body, every calorie that they gain, every calorie that they lose, when they work out, how often they work out. That might be the only way they feel like they're in control of their life. Other factors that they should look out for are things like how their family views food. Does their family have weird food aversions? Do they not like to eat together? Have there been comments made about how much this patient eats or how little this patient eats? This can be especially worrisome for younger people with anorexia. If family members pick at or joke about the amount of food that younger people eat, it might cause them to not want to eat at all. Either if they're making fun of them eating too much, then they feel like they're gaining weight, or they are eating too much, so they'll eat less. Or if family members are talking about how little they eat, the patient may feel like they should eat less out of spite or rebelling against their family members. It's also important for the patient to know realistic goals that are going to be set, and those will really help throughout the recovery process. It's important for the patient to know that this recovery is not going to happen overnight, that it is going to take time. That's important for them to keep in mind, that it's not going to be an instant thing, and this can really help feelings of guilt or feeling like they're not doing well enough. It's important for them to understand their basic nutritional needs. This patient needs to know these are the amount of calories, these are the amount of fats, carbohydrates, proteins that your body needs in order for you to function and live and feel good. And it's also important for the patient to know new coping mechanisms, better coping mechanisms than the ones that they're using now. Say this patient does have a control issue, the patient needs to be taught different mechanisms for fixing this issue where they feel like they need to be in control. There are other ways this patient can be in control, other ways that are healthier and are not harming the patient. Healthcare team member education is important for patients who have eating disorders like anorexia. Some of the members of that team for patients with that disorder are going to be the patient. Of course, patients are number one on the healthcare team. Family. Family is especially important for the patients who are underage, for teenage patients with eating disorders. According to our textbook, most of the patients who suffer from eating disorders like anorexia are from 14 to 18 years old. So family members, parents, guardians, those are especially going to be important in that patient's healthcare team. Also the nurse. The nurse is an important part of any healthcare team. And then there will be other members of the healthcare team for patients with eating disorders like therapists and dietitians, and then of course their primary care provider. One important thing for everyone to keep in mind is that the road to recovery for each patient is going to be different. Everything is based on a patient basis. It's not going to be the same for every patient with the same eating disorder. Nurses should especially be educated on what to assess their patient for. So daily weights are going to be very important. It's also important for nurses to keep in mind that patients with eating disorders, or any patient, should be weighed first thing in the morning after urinary elimination and a bowel movement. But then specifically for patients with eating disorders, they should be weighed with minimal clothing as they feel comfortable with, and it's important to check and make sure that that patient isn't hiding anything in their clothing, in their hands, and their socks, because patients with eating disorders have been known to weigh their pockets down with rocks or something, so it looks like they're gaining weight when in fact they have not. Other things the patient or the nurse should be educated to assess for is the fluid intake. It's important that patients with eating disorders stay hydrated. Their skin turgor and skin appearance. Patients with eating disorders are not getting enough water, they're not getting enough food, so their skin is going to be dry and cracked. It's important to assess their gait and muscle strength. this is a safety issue. If your patient is weak, if their muscles are weak, if they're walking kind of funny, you want to be able to implement the proper safety measures for these patients. So it's important that you know how strong is this patient. You know, do they need assistance walking? Do they need assistance out of bed? So that you can maintain proper safety precautions. And then especially heart rate and rhythm, because eating disorders, anorexia, extreme weight loss can cause the increased heart rate. It can cause cardiac arrhythmias. So that's something that you really want to look at, and you want a baseline for that so that you can continue to monitor that throughout their care. Therapeutic communication is also very important for patients with eating disorders. For a lot of patients, things that their family have said or social pressure is something that led them to this eating disorder. So it's really important to watch how you say things about food and how you say things about body image to patients. You never want to comment on their body size. You never want to say, oh, you're looking good, or you've gained weight. Those are things that you never want to say to a patient with an eating disorder. And you never want to seem judgmental. It's always important for nurses and any patients to self-examine their own beliefs and values, and those are things that we never want to impose on other patients, especially patients with eating disorders or mental disorders. We don't want them to think or know that we're judging them for not for their mistakes. That we're judging them for the position that they're in. We don't. That is not conducive to a safe recovery for patients with mental health disorders or eating disorders. It's also important for the patient to know some things that will happen with their care if they're staying inpatient, like checking their pockets and things during waits. Patients who have eating disorders, nurses are normally instructed to stay with the patient during mealtime. Also during mealtime, you don't want your patient to bring up food. Bringing up food and eating for your patient with an eating disorder during meal times is going to bring up negative feelings. And then that patient is going to associate those negative feelings with eating and mealtime, and that's not going to help their recovery process. Also, other procedures that are normally in place for patients with eating disorders is that not only does the nurse sit with them while they're eating, but they're normally supervised for 1 to 2 hours after eating, and then their bathroom visits are also supervised. We want to ensure that these patients are not having too many bowel movements, which could be from laxative use. We want to make sure that patients are not trying to get to the bathroom to vomit or throw up the food that they've eaten. So it's important that, at least for the beginning of their stay, that they are monitored throughout meal times, and that they're monitored after meal times, so that they aren't trying to undo the progress that they've made. Other things for healthcare team members to keep in mind is that normally patients with eating disorders have associated depression. So a big thing to watch for is any signs of intent to hurt themselves, to hurt others, or to commit suicide. If this patient feels like they're being made to eat, which they shouldn't feel like they're being forced to eat, but if they feel like this is not the path that they want to take, they don't want to eat this food, they don't want to gain this weight, this is ruining all of their progress, this could really do harm to this person's mental health, and they could potentially try to commit suicide. So that's definitely something that should be kept in mind and watched for. And then it's also for everyone in the team to keep in mind, the family, the patient, the nurses, the doctors, that it's hard to treat someone with an eating disorder because they likely don't think that there's anything wrong with them. They probably don't want this help. They think it's useless. They don't want to change. They like the way their body looks, or they want it to be smaller, and this is working backwards. This is undoing all the progress that they've done. therapy is going to be a big thing for this patient, and then also family support. The family should be taught how to talk to this patient, support groups, what they can do, what they shouldn't do, things like that, because you want the patient to continue this recovery process after they leave. And if the family goes back to doing the things that they've done before, that could undo all of the client's progress. So it's important for the patient to understand all of their education and take responsibility in their recovery. And it's important for the nurse to know all of the things to assess and look for. And then it's important for the family to be there for support and to know what their role is in contributing to this eating disorder, but also in the recovery process of this eating disorder.
It's me again, Nestor Mukeba. Now I am here to give a conclusion about on eating disorder. Um, as we said before, eating disorder it is linked to genetic. So there are some people they get this from their family, passed from generation to generation, and it is a damage in their brain. The brain, there are some regions in their brain that are damaged, and that make a dysregulation in neurotransmitters, especially in dopamine and serotonin in this case. So when someone has a dysregulation on dopamine, this person may have higher or lower dopamine, and when someone has a dysregulation in serotonin, it's gonna be the same. So the individual may have higher or lower serotonin. So if someone has a lower dopamine and higher serotonin, this individual will develop anorexia nervosa. And if the individual has higher dopamine and less serotonin, this individual will develop bulimia nervosa. And those individuals, for anorexia nervosa, the individual most of the time they lose weight, they look malnourished, uh, they don't like food, they skip meals, and it's easy to see that this individual has a problem because you're gonna see them losing weight. But the individual who is in bulimia nervosa, those individuals, they like food, they hide to eat, they eat in secret, they keep food in their car, so you see them moving from restaurant to another looking for food. Those individuals, so they have a linked, they have this disease because from genetic also, and they have a high level of dopamine in their brain, and that dopamine make them eat a lot. And those individuals, it is not easy to see them because they do stuff in secret. Uh, this is what we wanted to share. Also, I wanted to add that people with anorexia nervosa, they have a distortion of their body image. They think that they are overweight, but they are not, and they will keep losing weight, and if they don't get the proper care, they will end up in the hospital. Okay, this is what I wanted to share. This is what we wanted to share, and this is how we end. I hope you enjoy this presentation, and thank you very much.